Hello, everybody. My name is Paolo D'Arienzo. I'm one of the trainee representatives on the ACP/UK Society of Medical Oncology committee. And we've organized this tentatively monthly webinar with updates from experts in different specialties. Tonight, we're going to talk about breast cancer. We've invited two specialists in breast cancer from the Royal Marsden Hospital. We will start with Dr. Stefania Redana, who I will introduce shortly. But Dr. Stefania Redana is a consultant medical oncologist at the Royal Marsden Hospital in the Sutton branch, specializing in breast cancer and in acute oncology. She has trained at the University of Turin and the Royal Marsden and the Institute of Cancer Research previously. And she was a consultant in medical oncology at St. George's up to quite recently. Stefania, off to you. You're welcome to share your slide deck.
Thank you for inviting me, and I hope I won't be putting everyone to sleep with my talk tonight. So let's crack on. The subject is antibody drug conjugate in breast cancer. And these are my disclosures. So we're going to talk about what are ADCs and what their role is in different settings of breast cancer. So this is a fairly novel class of therapeutic agents aiming at combining monoclonal antibodies, cytotoxic agents through a chemical linker. And the aim of this type of treatment is to enable a massive delivery of potent cytotoxic drugs directly to tumor cells, trying to reduce side effects systemically. This concept was born a long time ago with Paul Ehrlich, who had the concept of the magic bullet, but we had to wait for a long time before this magic bullet was applied to oncology, and in breast cancer in particular, the first ADC was approved in 2013. Looking at how the ADC is built, there is a monoclonal antibody which is linked through the linker to the payload, which is the current cytotoxic drug. All these three parts play a very important role, which is summarized in this super busy slide that I'm going to dissect now. Looking at the backbone of the antibody drug conjugate, EGGs, immunoglobulin Gs, are the most common antibody backbone which is used for different reasons, because they normally have a low molecular weight, high affinity, and a long half-life. They also characterized by a high tissue penetrability, and in particular, the EGG1 also exerts multiple anti-tumor immune-mediated cytotoxic effect. The Fab region binds to the target, and the FC region promotes multiple anti-tumor processes. Looking at the linker, the ideal linker attaches the payload very firmly to the antibody in the circulation, in the bloodstream, but also ensures that the payload is very easily released when it gets inside the tumor cells. We have two different types of linkers, the cleavable linker and the non-cleavable linker. The cleavable ones can be chemically labeled and become unstable in the release the payload in an acidic environment, whilst the chemically cleavable linker are cleaved by cathepsin B, or the binding to the receptor on the tumor surface. The non-cleavable linker needs the antibody and the receptor complex to be internalized into the cancer cells and be destroyed and released via the lysosomes. This non-cleavable linker reduces the cell permeability, and therefore it has a slightly reduced bystander effect. And I will talk to you about what the bystander effect is. We have currently different payloads that are utilized, and the ideal payload is again highly tumor specific with a low molecular weight, enabling permeability, water soluble, and stable in an acidic pH. it should have a high cytotoxic activity, which is maintained in case the payload is not cleaved by the linker. And ideally, we would like to have a high drug-to-antibody ratio, so loads of payloads attached to the same antibody. The classic mechanism of action is that the antibody-drug conjugate binds to the receptor on the tumor cell surface. It is internalized and degraded into the lysosomes. The payload is released and can exert the intracellular cytotoxicity. The antibody-drug conjugate also leads to mediated death of the antigen-expressing cancer cell. If the payload can permeate the membrane, it can be released outside of the cancer cell and kill the neighborhood cells, and this is the bystander effect. There are also additional mechanisms of actions. So the ADC can promote all the immune-mediated cytotoxicity like the CDC, ADCC, and ADCP. And also, we know that antibodies such as trastuzumab, they can inhibit the pathways leading to cell proliferation. And this is a mechanism of action which is maintained by the antibody-drug conjugates. Currently, in breast cancer, we have 5 drugs which have been approved. Trastuzumab emtansine, trastuzumab deruxtecan targeting HER2, and then we have sacituzumab govitecan, datopotamab deruxtecan, and SKB264, which target TROP2. The latest 2 are only approved outside of the UK. The ones which are approved in the UK are summarized here, and I'm going to talk to you about that. Starting from HER2 positive breast cancer, the first antibody drug conjugate that was approved is trastuzumab emtansine, or TDM1. It uses a humanized anti-HER2 antibody, trastuzumab, that is bound via an uncleavable linker to a cytotoxic microtubule inhibitor. The drug-to-antibody ratio is 3.5 to 1. And this drug is currently approved as second-line treatment and beyond for HER2-positive metastatic breast cancer, previously treated with taxane and trastuzumab-based treatment. It's also approved in the adjuvant setting for those patients treated with neoadjuvant chemotherapy and residual disease post-trastuzumab-based neoadjuvant chemotherapy. The first registration trial was the Emilian study, where patients with metastatic breast cancer previously treated with taxane and trastuzumab were randomized to receive TDM1 or the former standard of care treatment, capecitabine and lapatinib. And the Emilia study demonstrated a significant improvement in progression-free survival and overall survival with TDM1 compared to capecitabine and lapatinib. Also very interesting is the safety profile, showing how TDM1 is way better tolerated than capecitabine and lapatinib. Therefore, there were attempts to bring TDM1 in earlier stages, and the Marianne trial looked at using TDM1 in first line compared to taxane and trastuzumab chemotherapy. It was a 3-arm trial, and as we can see from the progression-free survival curves on the right-hand side of the screen, there was no significant difference in progression-free survival amongst the 3 arms, meaning that TDM1 didn't overtake trastuzumab, pertuzumab, and taxane chemotherapy as first-line treatment, which continues being the standard of care so far. This was despite a improved toxicity profile. Looking at the utilization of TDM1 in early breast cancer, the Catherine trial is what led to the registration of TDM1 in patients who did not achieve pathologic complete response after neoadjuvant chemotherapy. And as we can see on the right-hand side of the screen, there was a significant 50% reduction in the risk of invasive disease-free recurrence in patients who received TDM1 compared to trastuzumab adjuvant treatment. In terms of safety profile, TDM1 toxicity was higher compared to trastuzumab single agent, but it was a manageable toxicity profile. Looking at the second antibody drug conjugate that was approved for breast cancer treatment is again an anti-HER2 antibody. This time the linker is a cleavable linker and the cytotoxic drug is a topoisomerase 1 inhibitor. TDXD is can permeate the membrane, therefore, it can exert a significant bystander effect, and the drug to antibody drug ratio is 8:1, meaning 8 molecules of DXD attached to one single antibody. It is currently approved for second line and beyond treatment for HER2-positive metastatic breast cancer, and outside of the UK is also approved in HER2-low metastatic breast cancer. The pivotal study was the DESTINY-Breast01 study that was a proof of concept showing how this drug led to significant response rate and absolutely respectful progression-free survival in patients heavily pretreated and led to the toxicity profile showing interstitial lung disease as a significant drug-related toxicity. There were 4 patients dying because of interstitial lung disease, and these led to guidelines and more accurate follow-up for patients in order to early detect interstitial lung disease. The DESTINY-Breast03 study was the phase 3 international study, randomized 1:1 in between TDXD and TDM1 for patients previously treated with trastuzumab and taxane in the advanced setting. Results of this trial show a highly significant improvement in progression-free survival and overall survival with the use of TDXD compared to DDX1, and therefore TDXD is now the current standard of care for second line and beyond. The benefit of TDXD was seen across all the subgroups that were analyzed into this trial. And very interesting, I always find these graphs very, very interesting, showing how almost all patients had some degree of benefit from TDXD. In terms of toxicity profile, hematologic toxicity was very similar, probably a little bit less thrombocytopenia. Gastrointestinal toxicity is higher with TDXD compared to TDM1, as well as fatigue. And again, we need to take into account the drug-related interstitial lung disease or pneumonitis that has occurred in about 15%, 1/5 of patients treated with TDXD compared to only 3% of patients treated with TDM1. TDXD has also demonstrated high activity in brain metastases, and this is very important because we know that HER2-positive disease frequently relapse into the central nervous system. There are different trials that have looked specifically at the activity within the brain metastases, and amongst those we have the Tuxedo trial that showed a over 70% overall response of the intracranial disease, followed by the DEBRA trial that looked at active intracranial disease, showing a 46% overall response rate, and the largest prospective trial, the DESTINY-Breast12 trial in HER2-positive advanced breast cancer with or without brain metastases, and shows in the brain metastases population an encouraging 12 months progression-free survival of over 60% and an almost 60% CNS progression-free survival as well. Coming soon is going to be presented in ASCO in a couple of weeks is the DESTINY-Breast09 study. There was a press release just a few weeks ago confirming that trastuzumab deruxtecan plus pertuzumab compared to combination of taxane, trastuzumab, pertuzumab has led to improved progression-free survival, and therefore we're all eager to listen to the presentation in ASCO. As usual, we try to bring these medication forward in earlier lines of treatment to improve the outcome of our patient. And in particular, a few trials have tested T-DXd in early breast cancer. In example, the Destiny Breast 05 is for patients who have not achieved the pathologic complete response after neoadjuvant chemotherapy, and patients are randomized in between T-DXd and T-DM1. We are looking forward to see the readouts of this study, and the Destiny Breast 11 is a trial that has used T-DXd in the neoadjuvant setting to evaluate whether T-DXd alone or followed by trastuzumab, pertuzumab, and taxane can replace the standard of care of docetaxel, carboplatin, and dual antibody blockade. We know that loads of breast cancer are HER2 negative, but the HER2 negative population includes a variety of HER2 staining. There are patients who can be HER2 2+ and not amplified, patients with a staining of 1+, or even now we're talking about ultra low, where the staining is just spotted on the membrane. So loads of antibody drug conjugate have been tested in the so-called HER2 low population, and in particular, the Destiny Breast 04 study was a large phase 3 trial that compared treatment of physician choice to T-DXd with the primary endpoint of progression-free survival in the hormone receptor positive cohort of this trial. The results are quite striking, and we can clearly see that in the hormone receptor positive cohorts, as well as in the whole population, T-DXd led to a significantly improved progression-free survival. There is also a significant trend in improved overall survival. Nevertheless, these results were not good enough or NICE to approve this treatment, which is currently not NICE approved. Moving on to the triple negative breast cancer population, we know that triple negative breast cancer accounts for about 15 to 20% of all breast cancer. These are normally very aggressive cancers. There is a high risk of early metastatization, and metastatic triple negative breast cancer patients have a really poor outcome. There is no specific target on the cell membrane, and what we know is that loads of different tumor types and cancer tissues are highly expressing TROP2, and triple negative breast cancer is one of those tumor types with high expression of TROP2. So this was the rationale to design a antibody drug conjugate that would target TROP2. So sacituzumab govitecan utilizes a humanized IgG1 anti-TROP2 antibody, which is connected to a topoisomerase 1 inhibitor, which is the active metabolite of irinotecan, through a cleavable linker, which is also pH sensitive and hydrolyzable. Therefore, it can exert a significant enhanced bystander effect. The drug to antibody ratio is 7.6 molecules per antibody, and SG is currently the first ADC approved for triple negative metastatic breast cancer patients who have received 2 or more prior lines of treatment. This is again the pivotal study that looked at a cohort of metastatic triple negative breast cancer patients treated with SG, showing significant response rate of about 30% up to 46% clinical benefit rate. And we can see in these plots the duration of response as well as the changes in the tumor burden. These pose the base for the ASCENT study, which is the phase 3 randomized study of metastatic triple-negative breast cancer patients who have received at least 2 prior lines of treatment. Patients were randomized 1-to-1 to receive sacituzumab govitecan or treatment of physician choice, and the primary endpoint was progression-free survival. Users to say this was a positive study, overall response rate of 35% with SG compared to 5% of treatment of physician choice, improved progression-free survival and overall survival. As we can see in the curves, there is about 60% reduction in the risk of progression, and there is also a significantly improved overall survival. As we can see from figure C, most patients derived a benefit in terms of changes in the tumor size. The toxicity profile showed that SG is well tolerated, with possibly any increased hematologic toxicity profile, slightly worse gastrointestinal toxicity profile, but all of this is manageable with accurate anti-sickness prophylaxis, and also the increased risk of febrile neutropenia is now mitigated by the use of GCSF. Because of the success of SG in triple-negative breast cancer, and because of the high expression of TROP2 in not only in triple-negative breast cancer, but in other tumor types, including ER-positive breast cancer, this drug has been tested in ER-positive breast cancer, and in particular, the TROPiCS-2 study was a phase 3 study in patients who had endocrine-resistant disease and previously treated with chemotherapy. Again, randomization 1-to-1 in between sacituzumab govitecan and treatment of physician choice. And response rate is higher with SG compared to treatment of physician choice chemotherapy. Statistically significant, but debatable clinically significant improved median progression-free survival, and similar results for overall survival. Nevertheless, the blue curve, which is the sacituzumab govitecan, is constantly above the red curve, which is the treatment of physician choice for both overall survival and progression-free survival and overall survival. The 1.5 months improvement in progression-free survival is what we need to ask ourselves if it is clinically significant or not. SG has been tested in different settings. In example, the NeoStar trial looked at response to neoadjuvant SG for triple-negative breast cancer, and amongst the 29 patients who received neoadjuvant sacituzumab govitecan, 15 achieved a pathologic complete response. And here on the right-hand side, we can see the changes in size compared to baseline in all patients who were treated with sacituzumab govitecan, which is encouraging. There is another antibody drug conjugate that targets TROP2. It is a different humanized IgG1 antibody, and the payload, so the cytotoxic drug, is different. Is a topoisomerase 1 inhibitor, DXd, the same one that we saw in trastuzumab deruxtecan. Antibody and payload are linked via a cleavable linker, and the drug-to-antibody ratio is 4-to-1. This drug can exert a bystander effect, and there was an early phase study looking at 44 triple-negative breast cancer patients heavily pre-treated, treated with Dato-DXd, and the overall response rate was encouraging at over 30%. Nevertheless, this trial led to an early approval by FDA, but this trial, unfortunately, is not. This drug is unfortunately not approved by NICE at the moment. The Same drug was investigated in the TROPION-Breast01 study, where patients with ER-positive, HER2-negative breast cancer previously treated and endocrine resistant were randomized to receive Dato-DXd or chemotherapy of physician choice. Primary endpoint was, again, progression-free survival and overall survival. This is, again, a positive study with improved overall response rate and disease control rate, improved median duration of response, and in the curves here you can see a significant reduction in the risk of progression of disease with 2 months gain in progression-free survival and an improved time to treatment failure as well. In terms of safety profile, Dato-DXd compared to treatment of physician choice was very well tolerated. The only side effect that was probably most significant with Dato-DXd was stomatitis. Now we can have a look at the future, at what comes next. So there is at least 150 ADCs in the pipeline of different pharmaceutical company, ongoing trials. So we are looking at new indication, how to overcome treatment resistance and how to optimize the sequence of this treatment. There are new ADCs and there are studies looking at combinations of ADCs with immunotherapy or other treatments. So if we look at the current treatment options for hormone receptor positive metastatic breast cancer, once we run out of endocrine lines, we have the option of chemotherapy, but there is now the option for HER2 low or ER-positive, HER2-negative breast cancer to receive different types of antibody-drug conjugates. Again, unfortunately, this is not the case in the UK, but hopefully it will be. If we look at HER2-positive breast cancer, what happened and what has changed in 2024 and what are we looking for in the coming year? We can foresee a role for antibody-drug conjugates in the early breast cancer setting, both in the early stages or in the adjuvant setting after neoadjuvant treatment. There are new drugs that become available in the metastatic setting, and there are more antibody-drug conjugate that can and need to be effectively sequenced in this setting. Looking at the triple-negative breast cancer, the management this year has significantly changed. So we went from having chemotherapy and possibly immunotherapy to having antibody-drug conjugate, which are now embedded in our standard of care, and there are new antibody-drug conjugate which are becoming available. We are exploring potential role of combination of antibody-drug conjugate and immunotherapy in both the neoadjuvant setting and adjuvant setting for patients who have not achieved pathologic complete response. There are new antibody-drug conjugates. We know that the importance of this drug is the high affinity of the antibody to the target on the cancer cells. There is a possibility of utilizing chimeric and partly humanized antibodies that lead to lower immunogenicity. We are looking at antibodies with a longer half-life and optimal drug-to-antibody ratio. We are also looking at different targets. So we have focused our efforts on targeting the cancer cells, but we can also think about targeting tumor vasculature, antigens in the stroma, in order to be able to deliver the payloads to a higher number of cancer cells. We can improve the payloads that we use, looking at payloads with highly potent cytotoxic effect. We can think of targeting different structures in the cancer cells, so not only the microtubules and the DNA, but other important aspects involved in the proliferation pathway. And also we can improve the linker characteristic, making it more stable in the circulation and with a more efficient release at the target site. And we can also work on the site of conjunction in order to make the drug distribution more effective. There are, as I said, combination studies looking at combining antibody-drug conjugate with immunotherapy. My favorite one is the Begonia study that was presented by Peter Schmidt recently. And this trial looks at combining Dato-DXd and durvalumab in first-line metastatic triple-negative breast cancer. This study showed a significant response rate of 79%. You can see in the plot that basically all patients had some changes in the size of their cancer, some reduction in the size of their cancer. And also the median progression-free survival is significant at 13.8 months, which is unheard in metastatic triple-negative breast cancer. There is other studies looking at SG and atezolizumab, like the Morpheus study, and again, highly encouraging overall response rate and progression-free survival rate. What can be the future direction for antibody-drug conjugate? We need to look at new indication, the role in first line and in the early breast cancer setting, especially for those patients with high risk of recurrence. In terms of future development, we need to look at the intensity, distribution, and dynamic of the target expression. We need to understand if the target matters. The target expression and selection is crucial to guide utilization of ADC in the future. Different payloads can have different relevance when we are trying to sequence different antibodies. And also we need to look at possibilities of combining different antibody-drug conjugates with different strategies such as immunotherapy. And this was my last slide. I'd be very happy to take questions, and I hope you're still awake.
We're definitely very much awake. Thank you very much for the comprehensive talk on this, very hot topic. So maybe one thing that came to my mind before, like how do you explain antibody-drug conjugates to your patients when you are consenting them? Because as we said, definitely the toxicities of chemotherapy with some differences, but the fact that they are going to be tired, that they might get significant nausea, they might have neutropenia, they are very much part of the toxicity profile. And I think maybe when I first approached this new type of therapeutics, I wasn't quite conveying to my patients that it's clever chemotherapy, but it's chemotherapy. What's your spiel like?
Thank you, Paolo. I'm glad I'm not the only one worried about explaining this to patients. So I think that antibody-drug conjugates are super clever. I think they are radically changing the natural history of breast cancer, at least, but they are not easy drug as we thought initially. I think we are far away from the concept of the magic bullet that delivers magic drugs with no side effects. And so when you explain these to patients, it is quite hard, especially because this type of treatment is continued until disease progression or unacceptable toxicity. And we are telling them that this drug will make them live much longer. So the patients are excited about the idea of having a prolonged survival, but they're also very, very worried about their quality of life. And we know that in the metastatic setting, quality of life is paramount. So it's one of our major objective and targets. So when I explain these to the patients, I try to sell it well. I'm not always very successful in this. But what I always tell them is that we will be together in this. They will not be alone. There are obviously loads of supportive medications that we can give them. We are working towards a more holistic approach. So, in example, exercises or trying to integrate different strategies in managing the side effects. There are plenty of initiatives the patients can join, such as working groups or webinars, talking to them about fatigue. Hair loss is a big issue because loads of the medications that we use in the metastatic setting do not cause hair loss or maybe just hair thinning. But in example, sacituzumab govitecan causes hair loss, and we are telling patients that they will live the rest of their life being bald. So these has a significant psychological effect on patients. So we need to be more proactive, not just in giving anti-sickness or GCSF, but in looking at our patients in a more holistic way.
Yeah, just linking to something that you've mentioned, the importance of supportive medication to improve tolerability. So you in terms of like adjustments that have been made to the protocols in your institution. So you did mention GCSF for everybody on SG. Did I catch it correctly?
I think that the Clatterbridge guided a national audit on neutropenic sepsis in patients treated with SG. And from that audit that was presented not long ago, there was clear evidence that prophylactic use of GCSF reduces the risk of neutropenic sepsis and as a consequence admission. So this is now built in our protocol so that patients receive prophylactic
Okay,
GCSF.
so not as of when required for a selected group of patients, no, for everybody who starts SG. Okay.
Yeah.
What about is there any, let's say for nausea, etc., is there anything else that is now built in?
In example, trastuzumab deruxtecan, we didn't think it was highly hematogenic, but since we started using that, we discovered that nausea is really quite significant. So again, I think that majority of our patients, it is built in the protocol that our patients get ondansetron, in example.
Okay.
And then we have been prescribing, in example, aprepitant to patients who still struggle with that.
Okay, great. Enough from me. So I'm gonna thank Dr. Redana for her very comprehensive review of this very busy aspect of treatment of breast cancer, and we can move on to the next speaker, who I think must be sitting next to her.
Thank you. Bye.
Okay, thank you very much. Okay, so
hello.
Hi, Nicolo.
Hello, Paolo. I'm not quite sure why I'm called Stefania Redana here on Zoom, but
okay,
I'm clearly not Stefania.
I'll make introductions so that people don't get too confused. So our second speaker is Dr. Nicolo Battisti, who's a medical oncology consultant in the breast unit at the Royal Marsden in Sutton. He has trained at the National Institute for Cancer in Milan and moved to and then Moffitt Cancer Center in Tampa, Florida, before moving to Royal Marsden. At the Royal Marsden, he leads the Senior Adult Oncology Group, and he's also past president of the International Society for Oncogeriatrics. I think I was struggling to get all of your CV in a few sentences, Nicolo, so please don't hate me if I forgot something very important. and he's going to give us an update on targeted therapies in breast cancer. Nicolo, over to you.
Thank you very much, Paolo, and thank you very much, ACP, for having me here this evening. It's great to see also a few colleagues also in the chat box that I had the pleasure to work with, Emma and a few more. So hello, everybody. I'll try to cover most concepts by the end of the meeting, which is, I think, if I'm correct, 7:30. I'll probably be trying to skip a few slides because we have a lot to unpack. So targeted treatment for breast cancer. This is my disclosures. I thought I could give you a very quick overview of how we use it, why we use it, and what are the key biomarkers that we routinely use in clinical practice in breast oncology. I will describe and talk you through what are the currently available standards of care. I won't spend too much time on future direction and research because, again, we could spend the whole day talking about all these topics. So a quick introduction, then CDK4/6 inhibitors, which is a big chapter in breast oncology, PI3 kinase inhibitors or inhibitors of the PI3 kinase AKT/mTOR pathways. A quick mention on ESR1 mutated breast cancer treatments, because we have a new approval very recently. Anti-HER2 agents, PARP inhibitors, and immune checkpoint inhibitors. I won't cover ADCs that obviously Stefania has covered in her talk. So this is a fantastic and very exciting topic in breast oncology because we've seen over the years since 1998 when trastuzumab was tested for the first time patient with HER2-positive breast cancer, an awful lot of development, as you can see here, in the space of HER2-positive disease, but also in the space of ER-positive HER2-negative disease in more recent years, and also in the space of triple-negative disease, essentially thanks to immune checkpoint inhibitors and, as Stefania discussed, sacituzumab. And over the years, all these fantastic updates have been also brought progressively forward in the curative setting, from the palliative setting, to again improve also cure outcomes, not only breast control outcomes in earlier stages of disease. Let's start with CDK4/6 inhibitor. CDK4/6 is a very important actor in the breast cancer progression. The pathway is critical because it essentially regulates the cell cycle, as you can see here, via RB1, the cyclin-dependent 4 and 6 kinase. When it's combined with cyclin D, it can phosphorylate and essentially inactivate RB1, which then releases the E2F growth factor that then pushes the cell cycle from phase G1 to the phase S. And there are lots, as you can see, lots of very important signaling pathways that converge on CDK4/6 and cyclin D, the MAPK signaling pathway, but also the PI3 kinase AKT/mTOR pathways that we're going to describe in a second. So this is a very important, as we will see in a second, very druggable pathway. CDK4/6 inhibitors completely revolutionized the management of ER-positive HER2-negative breast cancer, and this is something that we've learned in 2016 when the first CDK4/6 inhibitor became available on the market based on the PALOMA-2 study that you can see here, palbociclib, that when combined with an aromatase inhibitor, letrozole, is more effective in terms of progression-free survival and responses compared with letrozole, so aromatase inhibitor and placebo. Our previous standard of care for patients with advanced ER-positive HER2-negative disease up till that point was AI alone. Then we have to change completely our management of this patient population, and we had also to change our care pathways. Previously, we were seeing these patients every 3 months with staging scans and so on, then every 4 weeks. As you can see, there's been an improvement in the PALOMA-2 study of progression-free survival, approximately 2 years, but there's not been any improvement in overall survival. This has been a more recent update from 2023 that has gradually steered us towards using alternative CDK4/6 inhibitor that we'll see in a second, as opposed to palbociclib, at least for the larger proportion of patients. The toxicity of CDK4/6 inhibitor is predominantly hematological for palbociclib. As you can see here, the majority of these patients, 80%, will get some degree of neutropenia, but also 1/3 of patients might get some degree of alopecia. Always important to remember when consenting patients, and obviously anemia, thrombocytopenia in 15-20% of patients. Rash can be a problem, stomatitis, and decreased appetite. So these are all additional side effects that we need to be wary of on CDK4/6 inhibitors versus obviously AI alone. So in practical terms, palbociclib, that's the reason why we need to monitor the blood counts of our patients every 4 weeks. A bit later, we got data from Mona Lisa 2, which was the registration study of ribociclib in the first-line setting. Again, very similar setting, no prior treatment for advanced disease, ER positive, HER2 negative. And this patient randomized to receive ribo plus AI versus placebo plus AI. And this was a study that documented the benefit in progression-free survival. Again, very similar hazard ratios, as you can see here, very similar PFS, 25 months, 24 months on palbociclib. But this was also the study that documented benefit in overall survival. And this is one of the reasons why most recently we really switched in many centers, including our own hospital, from using predominantly palbociclib to using predominantly ribociclib, because we can ensure also that these patients enjoy an overall survival benefit. There are some additional toxicities on ribociclib compared with palbociclib, a higher rate, for example, of deranged liver function, around 1/5 of patients. This is something that we are auditing now in our own center, because my impression is probably a bit more frequent than 20%, but also QTc interval prolongation. So always make sure you keep monitoring these patients for the first 2 weeks of treatment on day 1 and day 15, cycle 1 with an ECG. This is something that may occur in less than 5% of patients, but something that can be quite sometimes challenging to treat if you're not being kept in time. And again, similar rates of neutropenia, hematological toxicity, and alopecia, as you can see here. Abemaciclib is the third CDK4/6 inhibitor, so the affinity of these 3 drugs to CDK4 versus CDK6 is slightly different, and that's especially the case for abemaciclib, which is the reason why in the registration study of abemaciclib with aromatase inhibition, MONARCH 3, again, very similar study population, the investigators documented probably less hematological toxicity. As you can see here, rates of neutropenia around 40%, but higher rates of diarrhea, higher rates of GI toxicity. As you can see here, now nausea in 41% of patients, and again, diarrhea in approximately 60% of patients. So this is something that really, let's say, identify a very specific safety profile of abemaciclib that differentiates it from ribo and from palbociclib, and certainly something that we need to be wary of when consenting patients for this specific treatment, because again, for somebody that may be having already some lower GI problems, IBS, IBD, and so on, or maybe more inclined to use palbo and ribo. Somebody that I'm keen on minimizing as much as possible hematological toxicity, maybe a concomitant diagnosis of CLL and so on, or maybe feel strongly about abemaciclib. There is also a risk of VTE, as you can see here, 6% in the MONARCH 3 study. It's always important to bear in mind when considering specific treatment. In terms of survival outcomes, again, abema in the first-line setting, MONARCH 3 documented is associated with a PFS benefit, a numerical overall survival benefit, but not statistically significant, as you can see here. So again, another reason why ribociclib has become increasingly the standard CDK in the first-line setting in the UK and many other countries. This is a summary slide. I won't probably spend too much time on this. We discussed these aspects already. There are some differences also in the dosing of the 3 CDK4/6 inhibitors. So again, palbo and ribo taken for 3 weeks on, 1 week off. Abema is a continuous dosing twice daily. So this is another practical aspect to bear in mind for the specific patient population. And there are very good data also in the premenopausal setting supporting the use of ribociclib. MONALEESA-7 was a study specifically designed to address the efficacy and safety of ribo in the premenopausal patient population, obviously with ovarian function suppression, guzerlin, documenting similar PFS and overall survival benefits. The first overall survival data actually came from MONALEESA-7 among the CDK. What about the second line setting? What about patients that actually relapse on aromatase inhibitors or endocrine therapy in the adjuvant setting? We have, again, three studies that similarly address this question around the efficacy of CDK in this specific cohort of patients with fulvestrant, so a selective estrogen receptor degrader, rather than observing another aromatase inhibitor. For example, again, PALOMA-3 was a study randomizing patients who had received previously endocrine therapy in the adjuvant setting and relapse on or after adjuvant endocrine therapy to receive or not palbo alongside fulvestrant. And again, this was a study documenting a progression-free survival benefit, not quite, unfortunately, an overall survival benefit, consistently what we've seen on in the first-line setting. Very similar safety profile compared with PALOMA-2. And similarly, MONALEESA-3 was a study looking at the efficacy of ribociclib with fulvestrant versus placebo plus fulvestrant for patients who had recurrent disease on prior endocrine therapy, but also patients that were actually treatment naive. As you can see here, approximately 50% of patients in MONALEESA-3 were actually endocrine therapy naive. So this was a much more endocrine sensitive patient population, also because this was a study that did not allow any prior chemotherapy in this patient population for advanced disease, differently compared with PALOMA-3. So perhaps not surprisingly, we've seen better results in terms of progression-free survival and again, overall survival in MONALEESA-3 compared with PALOMA-3, showing again benefits with a PFS around 20 months. And again, overall survival, again, not reached the latest reading, but 40 months in the placebo arm with very similar safety profile. Again, QTc interval prolongation around 5%, and obviously remember also the range liver function. There was also a study for abemaciclib in this setting. So again, patient with recurrent disease early on, within 1 year, or on adjuvant endocrine therapy or progressing on first-line endocrine therapy for advanced disease, no prior chemotherapy allowed with abemaciclib given alongside fulvestrant versus placebo plus fulvestrant, again documenting similar progression-free survival benefits, and again also overall survival benefits, so although probably less pronounced compared with MONALEESA-3. This was again a less endocrine sensitive patient population, so not surprising to see slimmer benefits. Similar safety profile. So again, CDK4/6 inhibitors are our standard option also for patients who have recurrent disease on aromatase inhibitors or early relapses on aromatase inhibitors, or for patients who are progressing on first-line aromatase inhibitors. They probably have not received, obviously, CDK upfront. Obviously, we have also looked at the use of CDK4/6 inhibitors in the adjuvant setting to try and increase the chances of cure for this patient population. MONARCHY was the first study documenting the benefits of using abemaciclib, a CDK4/6 inhibitor, with standard endocrine therapy. Could be tamoxifen, could be aromatase inhibitor with or without ovarian function suppression for a very high-risk patient population. As you can see, cohort 1, which is what the approval relied on, include a patient with at least N2 disease, or at least 4 lymph nodes involved in axilla, or 1 to 3 lymph nodes in the axilla involved with either grade 3 cancer or T3 and above cancer, so cancers more than 5 centimeters in size. And when patients were randomized to abema versus not, patients obviously the study documented the benefit in invasive disease-free survival. Again, with a nasal ratio of 0.66, as you can see here, so 34% reduction in the risk of invasive disease recurrence, but importantly also metastatic distant relapse-free survival benefit. Again, nasal ratio of 35%. So perhaps not surprising that this drug was approved in the early stage setting quite swiftly, as soon as here in the UK, as soon as obviously Monarchy was published and reported in 2023. So now this is a treatment that we use as a standard option in the adjuvant setting for 2 years alongside endocrine therapy, typically an extended course of endocrine therapy for this high-risk patient population. Safety profile quite similar in terms of diarrhea, VT, and hematological toxicity compared with the metastatic studies. Ribociclib is also proven to be effective in the adjuvant setting, similar to obviously abemaciclib based on the NATALEE study. Here we have shorter follow-up data, but this was a study that, when reported at ASCO, was shown to documented improvement in essentially relapse-free survival, but also distant disease-free survival for patients taking ribociclib for 3 years versus no-ribociclib alongside a non-steroidal aromatase inhibitor, so not with tamoxifen here. Importantly, this was a study that randomized patients to a lower dose of ribociclib, 400 milligrams, compared with the dose that we use in the metastatic setting. The investigators decided to do this to limit as much as possible the risk of liver toxicity in the adjuvant setting. This was a study that recruited a lower risk population of patients compared with Monarchy, but certainly higher risk compared with the overall patient population. So again, patient with stage 2A disease, so not negative, but at least with grade 3 or grade 2 disease with high-risk characteristics, whether that's Ki67, genomic tests, or patient with node positive disease, and stage 2B and stage 3 disease. So a broader patient population, overall lower risk compared with Monarchy. Good to see that there is a benefit here, but certainly that's something that we need to work out how it's going to play out in practice, because this is obviously a huge patient population that we will need to look after for 3 years on ribociclib. This is now available also here in the UK. This is again a summary table of the adjuvant CDK4/6 inhibitor studies. I wouldn't spend any time on Pallas and Penelope B. There were this negative study documenting no benefit with palbociclib in the adjuvant setting. Let's move on to PI3 kinase AKT-mTOR pathway. This is another crucial pathway in breast oncology, a pathway that leads to, cell cycle progression, proliferation, and obviously tumor growth. It's a pathway that is also involved in the glucose metabolism, and it's a pathway where there are 3 key markers, biomarkers, that are PTEN, AKT, and mTOR, that we can target with specific drugs, respectively, again, capivasertib and alpelisib, and obviously everolimus. Everolimus was a treatment that got approved based on the Bolero-2 study, which is a very old study published in 2012 by Jose Baselga. Was randomizing patients to receive it alongside exemestane versus exemestane plus placebo in case of disease progression after prior aromatase inhibition, letrozole or anastrozole, so the previous standard of care. This was a study, as you can see here, that documented benefits in terms of progression-free survival. Again, a median of 6.9 months, so not a massive median PFS, and no overall survival benefits. And those of you that have used this drug, they may already appreciated that this is a medication that sometimes is not free from side effects. We're looking at hyperglycemia, we're looking at pneumonitis, again, with rates around 12-13%. We're looking at stomatitis or mucositis in half of the patients, more than that. Rash in 1/3 of patients, diarrhea in 1/3 of patients. So again, a medication that doesn't always the patients may sometimes find quite challenging to receive. Our standard practice at Marsden to start patient with half the dose, 5 milligrams, and then escalate it to 7.5 or 10 milligrams based on individual tolerance. Response rates are also not great. And again, the other big caveat of this study is, what do we do nowadays? Does everolimus work post-CDK4/6 inhibitor? The jury obviously is out. This is not a question addressed by Bolero 2, of course. Alpelisib is obviously a PI3 kinase inhibitor, and more selective PI3 kinase inhibitors compared with the PI3 kinase inhibitors that were tested initially. They were found to be quite toxic. That got approved and licensed based on the SOLAR-1 study results for patients with PIK3CA mutated breast cancer, which is one of the mechanisms of resistance to endocrine therapy in this specific patient population, something that may occur in 40 to 50% of patients in this setting. And as you can see here, SOLAR-1 randomizing patient to alpelisib plus fulvestrant versus placebo plus fulvestrant upon progression on aromatase inhibition. There was also a population of patients within the study, a cohort with no PIK3CA mutated tumors, but there was no progression-free survival benefit in this patient population. The benefit was seen only in the mutated cohort. Again, the median PFS of 11 months versus 5.7 months on fulvestrant. This was a study that made us realize that giving nowadays single-agent fulvestrant perhaps is under-treating patients with ER-positive, HER2-negative breast cancer. But there was no overall survival benefit documented in the study, only numerical improvement, not statistically significant. This is another treatment that may be quite challenging to use in the clinic, unless obviously patient is really super fit and doesn't have any even hint of glucose intolerance. As you can see here, the hyperglycemia, something that was seen in the study in 63% of patients, diarrhea in more than half, rash in more than 1/3, stomatitis in 1/4 of patients, with a 25% rate of permanent discontinuation in this very selected study population. So again, watch out for patients obviously with glucose intolerance problems on this study, and make sure you monitor, check HbA1c and monitor glucose. Big caveat, we don't know whether alpelisib works after CDK4/6 inhibition based on SOLAR-1, and this is a question that was addressed by the BYLieve study. Again, looking at patients whose breast cancer was progressing on CDK4/6 inhibition. This was not a comparative study, as you can see here. It was a study simply looking at the efficacy of alpelisib plus fulvestrant plus post-CDK plus AI, showing again a progression-free survival rate 6 months of 50%, so not bad, quite decent responses, but certainly again same challenges in terms of the safety profile of this medication. Capivasertib is one of the new toys available in this space. This is a medication that's been approved in December based on the Capitello 291 study. A large study, as you can see here, that was randomizing patients to capi plus fulvestrant versus placebo plus fulvestrant, of course, upon progression on endocrine therapy, at least no more than 2 lines of prior endocrine therapy, even no more than 1 line of chemotherapy. Half of these patients had received CDK4/6 inhibition. So this was a positive study, again, documenting a benefit in the overall study patient population in terms of progression-free survival, but also importantly in overall survival, as you can see here at 18 months, greater benefit in patients with AKT pathway altered tumors. So again, patients with PIK3CA, AKT1, PTEN alterations. So this is a drug which is now available in England for patients with an altered pathway. It's available post essentially prior endocrine therapy. The safety profile is better compared with PI3 kinase inhibitors such as alpelisib, lower rates of diarrhea and rash, as you can see here, lower rates of hyperglycemia, 16% of patients, and lower rate of stomatitis. But certainly, again, because this pathway is involved in glucose metabolism, something to be very, very wary of also on capivasertib. We've been using this drug obviously in the study for quite a while. We now started using it in the NHS outside clinical studies, clinical trials, and that's something that we should also audit at some point. I suspect probably a UK level. Another kid on the block is elacestrant, which is now available for patients with breast cancer is ESR1 mutated. ESR1 is again another mechanism of resistance that breast cancer can develop, typically 2 years on average after breast cancer has been exposed to aromatase inhibition, so a mutation of the estrogen receptor itself that leads to the activation of the receptor itself. So Emerald was a study that essentially randomized patients to elacestrant, an oral selective estrogen receptor degrader, compared with investigator choice. Could have been fulvestrant, so it's similar, another selective estrogen receptor degrader, but given, as you know, intramuscularly, but also aromatase inhibitors, so perhaps an easy win compared with aromatase inhibitors. For patients with ER-positive, HER2-negative disease, progressing or relapsing on or early after 1 or 2 lines of endocrine therapy. At least one of these had to be given with CDK4/6 inhibitors. So again, a contemporary, obviously, patient population. Up to 1 line of chemotherapy was allowed in advanced disease setting. And this was a study that documented, as you probably can see in this very busy, probably very small Kaplan-Meier's, a benefit in progression-free survival, not yet in overall survival. It's a numerical improvement, but not statistically significant, versus all the standards of care, but also versus fulvestrant. So when you compare the two selective estrogen receptors degrader together, with a very good and excellent safety profile. 35% rates of nausea, that's the key side effect of elacestrant. As you can probably see here, again, the rate of progression-free benefit essentially at 6 months are 40%, so not huge. Response rates are not dramatic. I would expect response probably in 10 or less than 10% of patients, but stable disease clinical benefit rate in most half of these patients. So it's a medication that you can really use when you have patients with very endocrine sensitive disease, prolonged progression-free intervals on prior endocrine agents, maybe not a significant disease burden in visceral organs and so on. And certainly a very good treatment option also for patients that may not be that fit. A couple of concepts around anti-HER2 treatment. This is really a beautiful story that started with trastuzumab in the late 1990s. Then we learned that we can also use dual anti-HER2 blockade. We talked with Stefania about obviously antibody drug conjugate. This is a critical pathway that really leads to proliferation and cancer survival and cancer cell survival. We also have access to tyrosine kinase inhibitors here. Nowadays, tucatinib, but there are others that have been tested over the years. This is something that has really changed the natural history of this 15%, 1/5 of breast cancer patients that were previously relapsing very early, progressing rapidly and dramatically on chemotherapy alone. This is something that have significantly increased the chances of obviously overall survival, progression-free survival, disease-free survival, and the curative and palliative settings. This is a very good Cochrane meta-analysis that I'm sure you can look it up, showing what was also the degree of benefit with something like single-agent trastuzumab in this patient population. And nowadays, the standard of care in the first-line setting is what we call the Cleopatra regimen, named after this study that was the registration study of dual anti-HER2 blockade, trastuzumab plus pertuzumab alongside taxane-based chemotherapy in the first-line setting, or for patients progressing on or relapsing on adjuvant anti-HER2 treatment. Dramatic improvement in median progression-free survival, again, almost 2 years. Median overall survival, we're talking about almost 5 years now in the first-line setting, with obviously a safety profile which is typical of taxane-based chemotherapy. So docetaxel mostly associated with hematological toxicity. So make sure you cover this patient with primary GCSF prophylaxis. And ejection fraction, this drop in, again, less than 5% of patients. So again, a very well-established standard of care that, as Stefania said, is likely probably to be challenged by new kids on the blocks like trastuzumab deruxtecan, but we'll see. I won't cover ADCs, of course, but I thought I could mention also a TKI, the tyrosine kinase inhibitor, so that targets the intracellular domain of the HER2 receptor. Losing the extracellular domain is a mechanism resistant to anti-HER2 treatment in 1/3 of patients, so that's the reason why TKIs have been tested in this space. Tucatinib is currently available in the metastatic setting for patients who have progressed on Cleopatra, so anti-HER2 treatment, including also TDM1. So typically after TDM1, based on the HER2CLIMB study, which was a study published in 2019, with quite relaxed eligibility criteria in terms of brain metastasis as well. This was a study recruiting also patients with untreated brain metastasis, randomized to receive it alongside trastuzumab and CAPE versus placebo plus the combination, showing benefits in progression-free survival in the overall study population, but also in patients with brain mets, but also in overall survival, quite significant, as you can see here. Again, this was rapidly approved and licensed for use in the NHS. In this heavily pretreated patient population, is a less toxic TKI compared with neratinib and lapatinib because probably it's more selective for HER2 and involves less and does not bind does not bind as much EGFR. So rates of diarrhea overall, again 80%, but severe diarrhea 12.9%, much higher with other TKIs. A quick mention around pertuzumab, what we do also in the early stage setting. So neoadjuvant anti-HER2 treatment is a very well-established standard of care for patients with at least T2 tumors, so 20 millimeters and above, in the neoadjuvant setting based on, for example, Neosphere and Trefina, two studies that documented with dual anti-HER2 blockade versus single agent trastuzumab with or without chemo, quite high pathological response rate in 40 to 60% of patients. And we know how important this is as a marker of good prognosis or bad prognosis in a curative setting. So this is the reason why essentially we give it alongside, we give pertuzumab and trastuzumab alongside typically anthracycline taxane-based chemotherapy or docetaxel carboplatin in the neoadjuvant setting, as long as patients have a high-risk enough tumor. For smaller HER2-positive tumors, we don't need to worry about the neoadjuvant approach. We can give patients, can proceed with surgery up front, maybe it's followed by a de-escalated chemo anti-HER2 regimen. Couple of words on PARP inhibitors, two main mechanisms of actions, inhibiting PARP, so again, causing double-strand damage of the DNA, but also trapping the PARP DNA complex that essentially ultimately leads to targeted tumor cell death because of synthetic lethality. We have two PARP inhibitors available for breast cancer patients, olaparib and talazoparib, not the other ones that are maybe used for ovarian cancer and other malignancies. Olaparib is available for patients with advanced breast cancer in the presence of a germline BRCA mutation based on the Olympiad study. The randomized patient to receive olaparib versus chemotherapy of physician choice, including CAPE, eribulin, and vinorelbine, not carboplatin, interestingly. For patient with a germline BRCA mutation whose breast cancer was progressing on no more than 2 prior lines of chemotherapy and at least 1 line of endocrine therapy in case they had HR positive, so hormone receptor positive disease. This was a study documenting a benefit in PFS, again 7 months overall, so again not dramatic, no overall survival benefit in the overall cohort. The only benefit in OS was seen for patients receiving prior chemotherapy, but a much better safety profile, of course, compared with chemotherapy in terms of hematological toxicity, nausea and vomiting. Certainly nausea and upper GI toxicity and a bit of anemia are the key side effects of olaparib to be wary of. But overall, much better rates of grade 3 adverse events and better profile also in terms of quality of life. Talazoparib, similar study, and BRCA for this alternative PARP inhibitor for, again, advanced breast cancer patients with germline BRCA mutation, showing similar results in terms of overall survival and, again, progression-free survival, with a much better rate of grade 3 severe hematological toxicity compared with chemotherapy, perhaps not surprisingly. Again, similar standard arm, capecitabine, eribulin, gemcitabine, and vinorelbine. Olaparib is also a treatment that now we give in the adjuvant setting for 1 year for patients with, again, germline BRCA1 or BRCA2 mutations, HER2 negative disease. So it could be hormone receptor positive or triple negative based on the Olympia study that Andrew Tatt led on and published in 2021 in the New England, for patients who had completed at least 6 cycles of neoadjuvant or adjuvant chemotherapy containing at least anthracycline and or taxanes. So we typically use this option for patients with that do not have a pathological complete response on neoadjuvant chemotherapy, of patients with high-risk disease, for example, 4 lymph nodes involved in axilla at least, or large T2 or N-positive, not positive, triple-negative tumors, because Olympia randomized them to receive olaparib versus placebo for 1 year, documenting not only an invasive disease-free and distant disease-free survival benefit, but also an overall survival benefit, quite remarkably. And that's the reason why I got, again, quite swiftly approved also in the NHS. Safety profile very similar compared with the metastatic studies. And finally, immune checkpoint inhibitors. We haven't seen that much progress in breast compared with obviously lung or other tumor types. The two immunotherapy agents that we use are essentially atezolizumab and pembrolizumab in the metastatic and curative setting, as we will see in a second. There are lots of research on other mechanisms of action, different immune checkpoint inhibitors, but I won't cover that in this setting. Atezolizumab is approved based on PASSION 130, a randomized patient with triple-negative disease to receive it alongside Abraxane, nab-paclitaxel versus placebo plus nab-paclitaxel, documenting benefit in progression-free survival in this first-line setting for patients who had PD-L1 positive disease, not in all comers. And that's the reason why it got approved also in this specific indication. So you got to test for PD-L1 if you want to consider a patient for atezolizumab for triple-negative disease in the first-line setting. Again, as you can probably see in these busy slides, we're looking at again, 1 year progression-free survival rate around 20–30%. So not huge, certainly, but this is an option available that you can use in the clinic. Interestingly, in PASSION 131 was a study combining it with paclitaxel rather than nab-paclitaxel, and that study was negative. So, for example, this is a treatment which is no longer FDA approved, but is still available in Europe based on EMA recommendations. We had to learn as breast oncologists to deal with a number of side effects that we didn't know anything about because we didn't use immunotherapy before. So again, hypothyroidism, diabetes, all sorts of again, immune-related adverse events. But certainly, it's an option for this very challenging patient population with a high level of unmet need. Pembro, we have a study Keynote 355 that randomized patients to receive Pembro with different chemotherapy schedules, typically taxane or gemcitabine carboplatin chemotherapy, versus placebo plus chemotherapy, again in the first-line triple-negative setting, showing again progression-free survival benefit, and this time also overall survival benefit for patients with a CPS score of at least 10. So that's why it got approved for this specific indication. So again, you got to test PD-L1 either with this test or with the atezolizumab companion test. Again, rates of immune-related adverse events, quite important to bear in mind. There were some deaths also in this study, but certainly, you know, an important option to consider in this patient population, where essentially we only have sacituzumab govitecan other than standard chemotherapy. And finally, neoadjuvant Pembro. This is interesting. This is something that's become standard of care based on Keynote 522, a study randomized patient to receive carboplatin, paclitaxel, and anthracycline-based chemotherapy alongside pembrolizumab, versus placebo plus chemotherapy, followed by surgery, followed by adjuvant pembrolizumab until completion of 1 full year of treatment. For patients with large tumors and node negative or node positive tumors, so T2 and above, NEN, or patient with smaller tumors, T1C, so 10 to 20 millimeters in size, but not positive, again, triple negative. This was a study documenting benefits in terms of pathological complete response rates, as you can see here in 64% of patients, so rates that we see in the HER2 positive setting with anti-HER2 treatments now, but also a benefit in event-free survival, and benefit in overall survival, the latest reading, again, a 5% benefit at 5 years with pembro versus no pembro. Again, this is something that got very swiftly approved as well in the NHS based on this very nice data. But we got to make sure that we keep an eye on all the risk of immune-related adverse events. So especially for patients that go on to surgery, make sure you obviously check cortisol and various other problems to make sure they don't develop adrenal insufficiency before they go to the operating theater. In conclusion, again, targeted treatments are a very exciting field in breast oncology. We have very well-established standard of care among targeted treatments, essentially CDK4/6 inhibitors in the first and second line setting, PI3 kinase or AKT inhibitors like alpelisib, capivasertib, a few caveats on mTOR inhibitors. ESR1, a very good option for frail patients with endocrine sensitive disease, low disease burden. Anti-HER2 treatments has changed completely the management of this challenging disease, again, now more than 25 years ago. Immunotherapy available for triple negative patients, but again, there are still lots of questions that we need to answer to better select who are those patients actually are most likely to respond to immunotherapy, especially in the advanced disease setting. So we need to learn more and more on what are actually the mechanisms of resistance to all these wonderful drugs. And I think that's it. Hopefully, we're going to have a few minutes for Q&A. Thank you.
There are a couple of questions in the chat, so maybe we can start.
Yes.
We can start with those. So the first one is about PI3K mutation testing. So I do remember from my time with you, but off to you to tell us more.
Yeah, thank you, Ala. That's an excellent question. So I didn't cover it in the presentation, but essentially you can test anytime because that's a mutation or set of mutations that essentially are maintained throughout the whole disease trajectory. So, for example, you can test it already on a surgical specimen for patients with recurrent disease. Obviously, if you have the chance to arrange a request, a fresh biopsy of metastatic tissue, that's the best place. But any time during the treatment pathway. Now, in the NHS, this is something that takes a while to get the results for. So, for example, what happens in our clinics, as Paolo remembers, is that we sometimes test for P3CA mutations while the patient is still on CDK4/6 inhibitors or whatever other targeted treatment with endocrine agents, even in the context of stable disease, because we can get that tested on whatever is the last specimen available and pack that information for rainy days when the disease progresses, so that then we can switch the patient to capi or alpelisib upon progression. Now, in specific, you might also, things might change in the future. So this is something that you can now do in the NHS on tissue samples. But for example, I can tell you that in our center, we can also test it on circulating tumor DNA with quite a good level of agreement between ctDNA and tissue. So that's a much quicker and nicer way of testing it for patients, and also quicker turnaround that we get in essentially in 2 weeks. So now, to be honest, that's something that became available in our center at the end of last year within a specific platform that we call Marsden 360. That's become our standard route. But again, if you don't have anything like this available in your institution, I would suggest testing it as soon as possible, essentially, so that you have that information ready to use when the disease progresses.
Fantastic. And just so if I remember well, there are multiple different PI3K mutations, so I assume NGS is the right modality. Yeah. Okay.
Absolutely correct.
So the next question was from Rania. How do you choose between CDK4/6 inhibitors? I think you covered this to a degree in terms of the differences between the trials and which ones showed PFF benefit only versus OS benefit as well, which toxicity are typical of abemaciclib versus ribociclib or palbociclib. But one thing that Rania asks, which I think is something that would not be quite clear to me, is whether the size of disease matter. Do you have a preference with regard to that?
I would say, I think, as you say, Paolo, the safety profile to me plays a huge role. Even if we have an overall survival benefit on ribo that we don't have with the other CDK4/6 inhibitors, I think if I have a patient that I think would struggle on ribo because of QTC, because the patient is on QTC prolonging medications or have cardiac problems, or I'm a bit worried about compliance, adherence, or flagging side effects and so on, I would go down to palbo typically. But certainly, if I have a patient with no comorbidities, no concerns whatsoever, fit, young, healthy, rabo is my preferred choice. As I said, then you can decide maybe to go for abema if you're worried about hematological toxicity, but that's something, to be very honest, that we can manage pretty effectively in cancer care pathways, and we are very used to manage as oncologists. The rate of sepsis and infections in CDK is quite low, less than 5%. So although most patients on palbo and on ribo get hematological toxicity, actually quite a few get infections and get sick and unwell as a consequence of that. Does the site of disease matter? I would say if I don't think we have any pharma reps on this call. So if you talk to pharma reps, they may say, oh, if you have visceral disease, go down the route of abemaciclib because it's continuous dosing and it works better, and there are very good data from the MONARCH study program on visceral metastasis showing a very nice subgroup analysis. My experience, our experience also based on the studies that I very quickly discussed, is that not really, to be very honest. The only setting where I might feel more comfortable, for example, if a patient does not have extensive visceral metastatic disease, if the patient is not keen on considering a ribo or abema because of diarrhea, QT prolongation concerns, or if I'm concerned about going on ribo and abema, if, for example, a patient with bone-only disease that have very endocrine sensitive disease, maybe late recurrence or long PFI on previous endocrine therapy, where I might be okay, I might have a lower threshold to opt for palbo as opposed to ribo and abema. But again, that's really, our experience. But I would say choose based obviously on the overall survival data and based on the safety profile, because patients may also have quite lots of views on whether they like specific side effects or not.
Yeah, fair enough. Certainly true. I think there is another question in the chat, but I think it's Yuri, you said if there is no PFF benefit with palbo, there is a PFS benefit with palbo. There is no OS benefit.
Overall survival, correct. Yeah.
Okay, so if there are no other burning questions from our attendees, I do have a couple of questions because I've only left the team 8 months ago, but there are already.
We miss you a lot.
Thank you, Nicolo. I miss you too. There are so many new approvals, like within such a short space of time. So, for example, alpelisib certainly seemed quite a difficult drug because of rash, because of problems with hyperglycemia. Do you think capivasertib is going to be the death of alpelisib when they're going to prescribe alpelisib again? Have you used it? Because I just think the approval has only come through not too long ago.
December, yeah. I would say it's certainly a big challenge for whoever is manufacturing obviously alpelisib, because to be honest, if I have a patient with a P3CA mutation, why would I choose capivasertib, or why would I choose alpelisib as opposed to capivasertib in the context of a much better safety profile?
So capivasertib appears more tolerable.
Yes, and it's also a broader patient population because you can treat with capi patient with AKT and PTEN alterations.
And how frequent are those?
Far less frequent. 5%, I think, from memory, AKT, and again, similarly for B10 alterations.
Okay, but it's not an NTRK fusion that nobody has ever seen.
No, absolutely. And certainly, in our practice for patients that have a PTCA mutation now, that's become our standard choice. One of the questions that we have as a team, and again, that's something that I don't have the answer about now, is what to do. For example, are we going to be allowed, for example, to use alpelisib for patients that do not tolerate capivasertib for whatever reason, or for patients that are established on alpelisib now that are struggling and maybe need to switch treatment? Are we going to be able to use capivasertib? Based on the very funding forms, not. But that's something that I think as a community we need to start thinking about, because, for example, it's something that has become more of a practice for, with CDK4/6 inhibitors to switch patients among different CDKs. Somebody's struggling with ribo, then you can use palbo within 6 months of CDK treatment initiation. And whether it's going to be the same with alpelisib and capim, who knows?
And what about, you said, the NATALEE approval is, is in process. So let's fast forward. It's 2027, and both ribo and abemaciclib adjuvantly are approved. Is it going to be ribo for everybody?
Sorry, I didn't mention that, but actually it's been approved already.
Oh, okay.
And
So I missed out on that.
interestingly, despite NATALEE had a much broader patient population, has been approved in the same indication as monarchy. So now
wow.
you can choose, which is something that we didn't fully understand as team, but also as oncology community, because obviously, we were worried that it would have got approved for everybody because, again, stage 2A high risk, any stage 2B or any stage 3 is a much broader patient population compared with monarchy, and obviously patients that are coming to see us in the clinic every 4 weeks for 3 years instead of 2 years. How we're going to cope with capacity actually has been recommended for the same patient population. So,
but they have departed from the trial population, though.
It's a smaller patient population. It's about still within the study cohort, but they have restricted its use only to the very high risk patient population within NATALEE.
So within NATALEE, there were different cohorts, and this one was one cohort, and they've approved it for that.
An overall cohort, and they have identified within that cohort the high risk cohort, which is again T3 and above, or grade 3 with N1 disease or N2 and above. So again, my takeaway message is that I'm going to keep using abema for those patients for 2 reasons. One reason is that we have longer follow-up data for monarchy as opposed to NATALEE. The benefit is greater, probably because the patient population was high risk in monarchy as opposed to NATALEE, but also we have more solid, longer term follow-up. Second, it's a shorter course of treatment, which is good for patients. So 2 years instead of 3 years, 3 years of abema instead of 3 years of ribo. Good for patients, but also good for our services, because as you might remember, we are pretty much overwhelmed nowadays in breast medical oncology clinics.
Okay, so I kept everybody for a very long time, but I hope that everybody was as interested as I was in these talks. So once again, thank you to Stefania and Nicolo for giving us their time after a very long day in the clinic. Unless there are any final questions, I'm going to let everybody go.
Thank you, everybody.
Okay, thank you very much, Nicolo.
Bye-bye.
See you soon.
Good to see you all.